Cancer care or cancer commerce? Hello, I am Dr. K. Paul Stoller, and I have created a webinar on alternative cancer therapy at K. ENNETHSTOLLERMD.com now. Conventional cancer treatment has saved lives. Testicular cancer, cure rates over 95% in many cases. Hodgkin lymphoma, long-term survival dramatically improved. Childhood leukemias, once fatal, now often curable. In these contexts, chemotherapy is not a scam. It works. But that's not the whole story, because outside of these clear-cut successes, the picture becomes more complicated and more uncomfortable when benefit becomes marginal. For many advanced solid tumors, late-stage cancers of the lung, pancreas, colon, breast, chemotherapy often offers only modest extensions of life, sometimes measured in weeks or a few months, often accompanied by substantial toxicity and destruction of quality of life. And yet, it remains the dominant default. Why? Follow the money. Cancer treatment in the United States is a multi-billion-dollar industry. At the center of it is something called the buy and bill model. Here's how it works. Oncologists purchase chemotherapy drugs from manufacturers at a discount. They administer those drugs, then they bill Medicare or private insurance at a higher reimbursement rate. Under Medicare Part B, reimbursement is typically average sales price plus 6%. 6% sounds small, but when a single infusion can cost tens of thousands of dollars, 6% becomes real money. The more expensive the drug, the larger the margin. Incentives shape behavior. When reimbursement is tied to drug price, a subtle but powerful incentive emerges. Higher cost drugs generate higher revenue. Studies published in Health Affairs and the New England Journal of Medicine have documented cases where expensive oncology drugs with marginal survival benefit are widely used. Not because they cure, not because they transform outcomes, but because they are reimbursable. The 340B multiplier. Now add another layer. The federal 340B drug discount program allows certain hospitals to purchase drugs at steep discounts, sometimes up to 50%. They can then bill insurers at the full rate. The difference? Retained by the institution. This creates a structural reality. Cancer centers can generate significant revenue from administering high-cost chemotherapy. Volume and price become rewarded, not necessarily outcome. Regulatory silence. The FDA approves drugs based on trial endpoints that may include progression-free survival, tumor shrinkage, surrogate markers, not always overall survival. CMS reimburses based on formula. Lobbying pressure is real, and the system rarely asks, is this truly improving the patient's life in a meaningful way? The ethical question. This doesn't mean chemotherapy never works. It means the financing structure encourages overtreatment near end of life, aggressive intervention when palliative care might offer more comfort, default escalation, instead of careful restraint and ignoring any intervention that does not make the medical cartel big profits. The ethical issue is not that chemotherapy exists. It's that financial incentives may influence when and how it is used. Some cancers are cured by chemotherapy, and monoclonal antibodies are very promising. So some lives are extended meaningfully. But in many advanced cases, the survival benefit is 0 to nil. And yet the financial reward remains substantial. When reimbursement rewards expense rather than outcome, medicine drifts toward commerce. The question is not, is chemotherapy a scam? But when does it truly help? And when does the system incentivize its use beyond its real benefit? Because in cancer care, the stakes are not abstract. They are measured in suffering, time, money, hope. And hope should never be monetized without scrutiny, especially at the expense of alternatives that are much more efficacious, like the ones I discuss in my webinar at K. ENNETHSTOLLERMD.com. This is costing lives and destroying families. This is not just business, so follow the incentives. Then ask whether the system rewards healing or billing.